So for our last case study, I chose to do how pneumonia progressed to septic shock. I had a patient that presented in the ER, and once he moved to the floor, he was no longer my patient for clinical, but I kept up with this case because I became invested, spent a lot of time with him and the family, so I chose to use him as my case study. So we have a 79-year-old male, 5'9", 169 pounds. Like I mentioned, he presented to the ER via EMS. He came in on a 15-liter non-rebreather. EMS stated that when they found him, his family had called 911. His stats were 81%, and he only improved to about 88% once they placed that non-rebreather on him. He was also hypotensive and tachycardic. So we were already there waiting when EMS brought the patient in. They hooked him up to all the monitors, and it was pretty obvious that he was in severe distress. His heart rate was in the 180s. The ER tried to give him a volume bolus to help kind of stabilize that, and with no improvement, and after doing the EKG to confirm, they noted that he was an AFib with RVR, so they ultimately decided to do cardioversion. That was actually the first time that I'd seen that performed in the field. He let one of the other student nurses do that, so that was interesting to see. They did give him some sedation for that because he was alert and responsive. You could tell he was very agitated, very nervous and anxious, as I feel like anybody would be in that situation. So they did give him some medication to help calm him down in order to cardiovert him. So after he was stabilized, we were able to get a full workup on him, run all the labs, do all the things, and with a lot of help from his family, once they arrived, we were able to get a complete history. Obviously, he has that tachyarrhythmia. He remained stable in the 80s. Sometimes he would jump up in the 90s when he was talking. I noticed when I was in the room with him and his family. It became apparent once we figured out who he was. We saw in his chart that he had a recent discharge about a month ago for hospital-acquired pneumonia. So that was definitely a recurring problem as to why he was presenting in the hospital. He was having acute and chronic respiratory failure with hypoxemia. Ultimately, it was concluded that he was in severe septic shock, and the evidence for that was he was tachycardic, tachypnea. He had lactic acidosis, leukocytosis from that recurring pneumonia. He's hypotensive, and he requires supplemental oxygen, so he was hypoxemic. We do know that he has a history of COPD. He was also had a history of COVID about 5 months ago, and he kept saying over and over ago that this is when all of his problems started occurring. Once he got diagnosed with COVID, obviously he recovered from that, and he just feels like he was going downhill ever since then. Certainly didn't help that he also other comorbidities where he has type 2 diabetes, essential hypertension. He also had Parkinson's disease. I did not see any apparent signs of Parkinson's, so he might have been in the early stages. He didn't have trouble with speech or shaking or anything like that I could tell, but certainly that did not help to his overall health. So as I mentioned before, it was very apparent that he was anxious and agitated. I think he was just tired of being sick, if that makes sense. He did look like he's just been chronically ill, very pale. I'm not really sure why they wouldn't give him anything for his anxiety. I had heard that it was because he was hypoxemic, which is why they wouldn't give him anything for that. I definitely think that would have calmed his nerves a little bit. But nonetheless, during my assessment, his breath sounds were diminished. He had some wheezing and some bronchi as well. His extremities looked normal. He had no edema, clubbing, or obvious signs of cyanosis. His skin was normal, warm, dry. He was very pale, and he just looked like he was chronically sick, and which would make sense given his history. His neurological exam, he's oriented ×3. He knew where he was, who he was. So I feel like, his neurological status was intact. He did appear very thin, just frail, again, just very sickly looking, but he was cooperative. Anytime we tried to give him a treatment, he was willing to take it. And anytime we tried to wean him off that FiO2, he was willing to give it a try. But ultimately, we had to go back and forth, and I'll get into more of that later. Once he was stabilized and we got him off the 15-liter NAMA breather, we were able to take him down to a 6-liter nasal cannula. His vitals stayed in the his heart rate stayed in the 80s. BP became normalized, 120/85. He was breathing a little fast, but given his anxiety, I think that was what was attributing to that. Surprisingly, his temperature was normal, but we'll see later on the evidence of his recurring pneumonia. Here I tried to paint like a concise picture of his lab values. They were kind of all over the place, but this were the ones that I was noticing a trend in. His white cell count, initially came in, he was at 21.5. They gave him some medication, some antibiotics, dropped down to 12.6, and then ultimately started increasing in the other direction due to just the overwhelming inflammation of that sepsis that was basically just overcoming his body. His glucose, when he came in, was at 250, dropped to 137, and then back up to 215. I do think this was related to his type 2 diabetes. We know that when it's uncontrolled, it contributes to your recovery of bacterial infections in general. So that certainly did not help his case. Then we can jump down to his procalcitonin, which we know is an obvious indicator of pneumonia. Came in a little high at 0.31. It wasn't checked again until the 27th, which it had significantly jumped up to 1.3, again contributing to his overwhelming sepsis, and the pneumonia was just taking over his body, and we'll get into just a minute what else he had going on. So here I tried to paint another picture of what we were doing regarding his ABGs and relating that to his oxygenation needs. Like I mentioned, he came in on the NAMA breather. We were able to bring him down to that 6-liter nasal cannula. Then he just started increasing that oxygen needs. So we went to the 10-liter pendant. From there, he just kept asking. He felt like he couldn't breathe. I really think it was because of his anxiety. I don't necessarily think he needed that BiPAP. For whatever reason, he just felt safer with that on. Maybe he felt like he was getting more air because of that flow coming from the BiPAP, and that just made him feel better overall. So at least for the couple of days that I had him in the ER, we were going back and forth between the pendant and the BiPAP. Based on his ABGs, 100% was way too much. We reduced him down to about 60%. And then I tried to get him to wean down from 10-liter to 6-liter pendant. And then again, maybe within a few minutes, he would, I think the most he ever stayed on it was probably about 30 minutes. And the nurse was calling me right back to switch him back to the BiPAP. So that was just kind of the issue we were having there. He, like I said, he remained stable. His stats were in the mid to low 90s on that pendant, but for whatever reason, he just felt safer with that BiPAP on. Once he did get to the floor, we were able to transition him to that high flow nasal cannula. I think he felt a little more secure. Once he got to the floor, he was more stable, so we were able to keep him on that high flow nasal cannula. At least I didn't have him, but I followed his case, and he was able to remain on and off that. Okay, so here's where things start to get a little messy. So he had an initial chest x-ray, and as the radiologist indicated, I even looked at the x-ray myself to kind of see what was going on. He had increasing consolidative opacity in the right lung. His left lung was normal. They compare this to his chest x-ray from when he was discharged a while ago, and compared to then versus now, it obviously gotten worse, hence why his stats are dropping and why his family called 911 to bring him in. They also did a chest CTA same day, and unfortunately it revealed he had a large mass with some cavitation in the right upper lung. They're really suspicious for malignancy, and on the differential diagnosis it could just been an abscess. But he also had enlarged mediastinal nodes and some obvious patchy consolidation that was coinciding with that chest x-ray. A couple of days later, he got another chest x-ray. That consolidation had increased to throughout his entire right lung, and then they could see that pneumonia was surrounding that pulmonary mass as well. The next day, radiologists concluded that it was near complete coverage of that right lung field, and then he was starting to develop atelectasis in the left base. Definitely could be contributed to not deep breathing, even though he's on that supplemental oxygen. I feel like he wasn't taking deep breaths, so with that reduced effort, that atelectasis was sure to develop. A couple days later, and then the last chest x-ray, he had complete opacification in the right lung, and then was getting those patchy alveolar opacities in the left lung base, again just worsening of that atelectasis from reduced breathing effort. So here I've listed all of his relevant medications. For respiratory, he got nebulized treatments either through, most the treatments that I gave him were given through the BiPAP. He seemed to tolerate that pretty well. We were giving him Xopenex with Atrovent because of his history of tachycardia. We know that we don't need to give Duoneb because it could increase our heart rate, and we didn't want to jeopardize that again. So 4 times a day he was getting that along with the Pulmicort. So something happened to my slide, but I just wanted to mention the other non-respiratory medications he was on. They put him on Eliquis. We know that's an anticoagulant. He was on Lasix because initially they thought he was in fluid volume overload. Then he was on the antibiotics vancomycin. Not really sure how to say that one. Piperacillin sodium tazobactam. He was given some morphine for pain and acetaminophen, which is like Tylenol. And then he was giving lots of fluids to correct his electrolyte imbalance as well. So on this slide, I just kind of wanted to do a brief timeline of what happened. He, like I mentioned, came into the ER, and he stayed down there for a couple of days because unfortunately we have no rooms available. So he stayed down there for a couple of days, and I mentioned he was on and off BiPAP, rotating from BiPAP to the pendant. he had that very obvious anxiety. His family was present. It was his daughter and her husband, and they were there for emotional support. His wife is in a nursing home. She's got severe dementia, and he was very concerned about her the whole time as well. But eventually he was able to go up to the 3rd floor. That's the progressive care unit for us. They did want to do a bronch, but it was determined that he was too unstable in his current condition to undergo that in order to get a biopsy to figure out exactly what that mass was. I think they were pretty spot on that it was cancerous. And again, based on his social status, I think that the family wished not to go down that route. They were trying to do what was best for him and try not to do something so invasive, given his condition. Then over the next week or so, as I mentioned, his chest x-ray started to progress, and they actually consulted infectious disease to try to combat that, and then he was able to be put on that high flow nasal cannula and stay off that BiPAP, switching back and forth, basically just trying to wean him off that supplemental oxygen. But it just that infection was taking over his body, obstructing his airway, so he needed that extra flow to get the oxygen in. It was later determined that his outcome was very poor. The pulmonologist, hospitalist, infectious disease, they all talked to him and his family regarding his code status. He chose to become DNR. Then it was clear that he was just starting to take a terrible decline, so they called in palliative care, keep him comfortable until the inevitable was soon to happen. Eventually, he did expire. I was really sad to see that when I came in one day and looked at his chart. Basically, he just coded. The nurse came into the room. He was asystole, unresponsive, no breath sounds, and due to his code status, obviously, they were not able to resuscitate him, and he unfortunately passed away. So I know we're still learning as students, but based on what I saw initially in the ER, that was not my initial outcome, that he was going to pass away. I thought we were just going to treat him for pneumonia, get his anxiety under control, maybe get him some counseling regarding his wife. He's apart from his wife, and I think that was taking a toll on his mental status, and we know that stress exacerbates any kind of inflammation, infection, so I don't think that was helping his case at all. Even if we were able to do that bronch and figure out what that mass exactly was, I think he was just too far gone to be able to do any kind of resection or chemo, radiation, anything like that. I think, just being chronically ill, I don't think he would have had any good outcome or any real quality life if he were to go down that avenue, even if he was stable enough to undergo a bronchoscopy. So basically what we were doing, we were just maintaining his stabilization, we're still working on weaning his O2, support that blood pressure and monitor his heart rate, make sure he doesn't go back into the 150s, 180s like he originally presented. Couldn't find anything specifically related to septic shock in the Desjardins book. It talked about sepsis in regards to ARDS, and I don't think that was the same case here. So I went online and used the Cleveland Clinic to get a list of classic signs and symptoms of septic shock. We do know that is the last stage of sepsis. I've listed out here what they say are the typical signs and symptoms and how they present. And then on the right side, or excuse me, on the left side, and then on the right side, I listed out his actual presentation, which was pretty on par. He was hypotensive. He did have very little urine output. That's why I was confused what the Lasix was for in the beginning versus towards the end. I just don't know if that just wasn't working because he was going into multi-organ failure and everything was just starting to shut down, would be my guess. As I mentioned, he was pale and he just looked like he was chronically sick. We did have the presence of a bacterial infection, that pneumonia, and we have the evidence of the procalcitonin levels to back that up. And of course he had the high white cell count. He also had a low red blood cell count, low hematocrit. His history was consistent with the high glucose as well. And then on his BMP, his chemistries, he did have initial low sodium, chloride, and magnesium, which was why he was on fluids to help correct that electrolyte imbalance. And we do know that he did require that supplemental oxygen. Inflammation was just consuming his body and obstructing his airway. So we were trying to keep him comfortable and not go into distress again. And then ultimately, it said that organ failure can be a result of septic shock. And essentially, I think that's what happened and why he essentially passed away. Like I said, I did kind of get attached to this patient. I was really sad that he passed, but I really think that's just what he wanted. He was just tired of being chronically sick, and with his wife not doing well, I don't think he had very much life left in him. So I think, he's in a better place at this point, and sometimes that's just what happens with our patients. We're here to care for them in their time of need and just kind of ease them into whatever care they need as well. So I did learn a lot from this patient. And, like I said, I initially thought he would come in, and what actually happened was not what I thought. But